Hi, my name is Sam Klempner. I'm a GI medical oncologist at Mass General Brigham Cancer Institute in Boston, and I'm here to talk about perioperative therapy, specifically the MATTERHORN trial in gastric and gastroesophageal junction patients. Going back a few years, we've seen the increasing predominance of perioperative therapy, chemo, before and after surgery. This was originally developed in Western patients with the FLOT4 trial, and then solidified with the ESOPEC trial comparing perioperative FLOT against chemoradiation. And having established FLOT as one of the preferred global backbones for perioperative therapy, the Matterhorn asked a very pragmatic and clinically relevant question, which is if we add checkpoint inhibitors on top of standard perioperative FLOT chemotherapy, can we improve event-free and overall survival? And of course, the activity of checkpoint inhibitors is established already in this tumor type from the metastatic disease trials. And so moving this earlier has been a paradigm that's been successful in other tumor types. So on that background, the Matterhorn trial was launched. This is a large global phase 3 trial accruing about 950 patients with operable gastroesophageal junction or gastric cancers. If you look at the demographics, you'll see that I think this is a pretty real-world population, similar to what we see in clinic. The vast majority of patients are clinically node positive, T3 or higher tumors. So these are true locally advanced cancers. Always important to make sure these patients are accurately staged and have early surgical involvement for discussions. But this was a global trial. About 20% of the patients came from Asia, so establishing FLOT sort of as a global ability to conduct. And then the primary endpoint was event-free survival, and overall survival was a key secondary endpoint along with pathologic complete response. This data was originally presented at ASCO in 2025, where the primary endpoint was reached. So there was a statistically significant improvement in event-free survival, 2-year event-free survival rates about two-thirds versus about 60% in the control arm. And then more recently at ESMO, we saw the presentation of the overall survival data, which is always important to validate the early surrogate endpoint. And the overall survival data was also positive. So here the hazard ratio was 0.78. The p-value was statistically significant. And if you look at the 3-year overall survival rates, it's approaching 70% in the durvalumab, the DFLOT experimental arm, versus the FLOT arm alone, about 62%. So in my opinion, this trial has checked both the boxes, improvement in primary endpoint, as well as hitting on the key secondary endpoints of OS and PathCR. There's also some very interesting data in the associations between pathologic response and event-free survival that was shown at ESMO, certainly supporting the idea that it seems that patients who have some degree or very good pathologic response to neoadjuvant therapy are having the best outcomes. But the addition of durvalumab to perioperative FLOT did improve the outcomes across the entire intent to treat population. In my own practice and many other people's practices, this has been adopted as the standard for essentially all comers, independent of PD-L1 status or clinical nodal status. And that is, in my opinion, the current standard of care. FLOT is, of course, has its known toxicities, but this is a manageable with early dose reductions and modifications, and essentially all patients able to receive the neoadjuvant component, and a majority of patients able to get the adjuvant component. It does appear important that patients do receive all of the therapy that they are able to maximize the potential benefit. So this is really our first trial in the perioperative setting to establish immunotherapy as an active agent. And certainly the future is very bright to build on this with additional biomarkers and a lot of correlatives to mine. So thank you for your time.